We're on to the part of the discussion where we're supposed to talk about the management of severe or complex cases. And I was anticipating, how do you start with somebody who's severe or complex? And maybe most of what our experience is we get severe or complex patients who are in the middle or kind of at end stage treatment. And what do you do with them at that point? And sometimes it's dismantling, but sometimes are there other alternatives? What do you do with the patient who's the most difficult?
I agree with you, Larry. We see a lot of these patients, and it's not just 3 medicines, one for tics, one for ADHD and OCD. It's usually 4 or 5, because topiramate is in there, and Lamictal, and all the sexy anticonvulsants that we know nothing about with mood disorders in kids yet, let alone tics and Tourette's. So the more drugs you have on board, obviously, the more interactions there are, the more secondary complications, and sometimes just peeling it back one by one, thinking what's the least expendable here, and going back to basics can be very helpful. The other thing is, depending upon where we see the child in cross-section, there's been a developmental course of all of these disorders, and what may have been necessary at age 8 may not be so necessary at 13 or 14, but many times patients end up staying on these medicines tweaked up and down for years, and so it's really important to reevaluate each of
People
those
add instead of
symptoms.
subtract.
Yes, yeah.
So let's say you have a child or an adult with a very severe quote-unquote Tourette, that is, it takes it out of control, the OC symptoms that are out of control. There's probably some attention deficit disorder problems that got buried into the others, and they are on 5 medications. And you're trying to do this as an outpatient, so where do you start?
What John mentioned earlier is getting the trajectory of each one of these medicines, and in a process of doing that, to try and point out to the patient, if it's an adult, or to the family, that really didn't get them where they wanted to go, because then they're a little more amenable to considering the dismantling. The second thing is what was the last medication added to the mix is another important little strategy that I think about, because that almost, and now I won't say all the time, but a lot of times, is meant to deal with some adverse effect from one of the prior medicines. So that's an important little tip for me in the dismantling. And then the third of all, the short-acting medicines. What's the short-acting medicine in the mix? I'll take that away first usually. So those are kind of my 3.
Those are the ones that are most likely to give you a withdrawal reaction that would then backfire in terms of symptom management. So you're going to get a little bit more withdrawal from those than some of the others. I agree in principle, but that requires yet another layer of education, switching them, if it's a benzo, from a long-acting to a short-acting to then affect the withdrawal. If it's the SSRIs, going into one that's perhaps more long-acting, that will be less likely to produce a withdrawal at the time that you're pulling back on a certain medication.
No, when I meant short-acting, I meant something like a stimulant.
Oh, I see.
Yeah.
Okay.
Yeah.
But you're really talking about sophisticated dismantling. How to get not just clean up the picture a little bit, but how to clean up the picture.
And even before you start cleaning up the picture is who's going to be the witness to the consequences of that cleanup? I mean, are you going to see the child once a week? I think you almost have to in order to do that.
Yeah.
I actually
don't expect that. Okay, I'll see you in 5 months. Expect that that's going to work.
No.
Or a 6-week tapering schedule.
Yeah, no.
These are often people who they have more experience with these medications than any of us ever will, because they actually had to take them. So I basically approach these folks as equals and say, okay, you tell me what you think worked, and let's develop a plan.
Yeah.
And let's try to stick with the plan. And I throw in my 2 cents, and that is, if you're on 6 milligrams of risperidone and you're still ticking a lot, well, that's probably not doing you any good, so why don't we stop that or taper it? It's surprising to me how seldom the tics get worse.
Well, they tell you very often, at least the adults, that, gee whiz, this may look bad to you, but this is very nice compared to what it used to be before I got on to 6 milligrams. So the 6 milligrams has not gotten me to the promised land, but I'm still like 5 miles from the desert, So it's very complicated in adults, and they're very opinionated, and they can get an idea in their mind that it's very hard to extract. It's like pulling teeth. So I agree in principle, but the adults are very complicated that way.
Oh, yeah.
And when they tell you that, yeah, this looks bad to you, but boy, it looks a lot better to me from where I'm standing, because I may be sedated, I may be stumbling, I may drop my blood pressure, so I stand up very quickly, but I'm not hitting myself, I'm not biting myself, I'm not, I'm able to go out in public and things like that, or at least to a few places in public, kind of.
Well, that's just about getting that history. And getting some humility about what you're doing with people, because if they're really in a better place, but you look at their treatment regimen and their past treatment as something that isn't right, you're missing the boat if indeed that treatment regimen has brought them some symptom relief. So I
They
think
often don't want to change much.
yeah.
Don't know
The question is, can you make me better? And the answer is no, probably not.
The question is what? And one rule of thumb I've developed over the years of having had a lot of experience with this is, if there's more than, let's say, 3 or 4 medicines on board or medicines have been added, that you have to stop and reevaluate what the diagnosis is. Because medicines have been slapped on for this or that symptom, and yet the kid is in a developmental state, and what is going on that's new that might be underlying the mood instability or the anxiety that's now coming up that a medicine has been added for but needs to be rethought from the beginning. So that's always a sign for me. 3 to 5 medicines on board, need to rethink diagnosis here of what's going on.
I think one of the ways I try to think about it, I think, we see people who come in with patterns of problems. And even the people who seem to have unusual or idiosyncratic still have patterns of problems. So, and we've all been in the business long enough to recognize what those patterns are. And we also have patterns of pharmacotherapy that we know, even though there may not be great evidence for, we have patterns of pharmacotherapy that sometimes match that more or less well, and sometimes those extra medicines are just little extra pieces that don't quite fit on there, and so sometimes I think
You can knock them off.
we can knock those off and get back to something that's more plain and simple, and at least put you in a position where you can kind of make changes or do something different that might offer some additional benefit.
But I agree with the point you made that sometimes adults or families, they say, oh, gee, I know this is a strange cocktail, but it's a lot better, and they don't want to change. But I also find the reverse, that some parents are relieved to hear that you're really going to consider dismantling this thing, and that you really have some notion that they've thrown one dose too many, or one drug too many, or 2 drugs too many, or good dose after bad dose, so to speak, and that you are willing to dismantle this thing is relieving.
But dismantling is a major treatment commitment.
It's a major treatment commitment.